What's the worst mistake you've made as a doctor? Before we get started, make sure you're subscribed to the channel and turn on the bell so you don't miss future videos. Thanks for the support. It was a mistake that has been foundational to my development and how I practice today. Throwaway and anonymizing as much as you can on here though. A few months into my F1 4 years ago, very understaffed, meant to be a consultant-run ward, and I was finding myself leading my own ward round of a bay of 5 apparently reasonably stable patients as a new F1. Quite overwhelming at times, and genuinely unsafe in retrospect. Not making excuses to the mistake to come, purely context. A patient under my care was clearly anemic, secondary to larger issue. Highlighted it to my cons who came to review again with me. Afterwards, he told me to chase the investigations into his underlying issue, transfuse, and make sure you inform the family. Over the course of the day, the transfusion was continually delayed. I chased it all day. Finally, around 3 p.m. it was started. The cons called me and asked me what was going on. I explained. He ended it with, "Okay, great. Again, just make sure you call the family before you leave." Now, for more context, excuses, I had also spent the entire day sinking my life and soul into a discharge for a clinically stable but terminal pancreatic cancer patient. By the time it got to 4 p.m., clocking out time, I thought about calling the patient's family. Exhausted, I looked at the anemic patient, transfusion running through. He looks all right, I thought. I remembered the last time I called his family. They were talkers. Lots of questions. Ones I would almost certainly not be able to answer. I specifically remember thinking, this is ridiculous. I've been run off my feet and cannot be bothered dealing with the family right now. He looks fine. He'll be fine. I call them tomorrow. I handed over the patient to the on-call F1 for post-transfusion HB check and went home. Really struggled to sleep that night. Got in the next morning and just felt off about it. In the doctor's office, I decided to check the patient notes before going in, which I'd never done before. He had deteriorated overnight and passed away. I walked onto the ward, sick to my stomach. I knew it was unlikely anything could have changed things clinically, but I knew that the family would have been completely blindsided, and they were. My consultant had a chat with me, running through what had happened overnight. He ended it with a question. "Did you speak to the family?" To which I answered that I had not. He didn't say much, just acknowledged it at that time. I have never felt such an immediate and powerful shock of shame before, or thankfully since. Later that day, the family came in. My consultant asked me to attend a meeting with them, where we went through the clinical side of things that led to his deteriorating, etc. I sat and listened as they explained how much of a shock it was to them, a shock I destined them to. In retrospect, I did not quite grasp how unwell this patient was. I did not understand how easily he could, and did, deteriorate. Even if I did call them, I'm not sure I would have prepared them any better for what was to come. I learned a lot that day. 1. Your consultants often have experience and knowledge you simply have no concept of as a proper newbie. In this case, the possibility for deterioration. 2. If you are unsure of the reasons why you have been tasked something, ask. 3. Most importantly, talking to the family is a crucial part of the job. It isn't just another thing that can wait. This was something I had naively become jaded to. I've never made that mistake again. Would be good to know others' thoughts on this. Next story. At work in general surgery in the second year of residency, I did 7 on-calls in a row, and they were brutal. My brain would often mush by the end of them. During one of those on-calls, I remember clerking a guy with painful jaundice and a nasty CT highly suggestive of cancer. Neither me nor the reg felt comfortable disclosing the likely diagnosis. On the rapid-fire post-take surgical ward round, we also didn't have a proper opportunity to break the bad news, but the straight-talking mid-50s man asks me specifically what the CT showed. I couldn't think of a viable deflection quick enough, and he asked me if it showed cancer. He was devastated, and I had to run after the ward round. Cut to around 4 weeks later when I bump into him when he's admitted again. That guy actually had Maridzi syndrome, and he didn't have cancer. I was happier than him. Next story. Prescribing Comox to a pen-allergic patient, and the nurse not catching it either. It was a very tense few hours waiting to see if he had a true allergy to penicillins. Felt crap for days afterwards. Next story. Already an awkward person, but in therapeutic department FY2 rotation, as I was leaving the room to ask my supervisor for advice, I tried to exit too quickly, didn't open the door properly, and banged my head on the partially open doorway. I was instantly mortified. and, for reasons I still don't understand, I apologized to the patient who looked painfully uncomfortable and just cringed. Next story. Completely swamped ED shift as an FY3 and jumping between jobs and patients, asked to prescribe blood thinners for PE handed over to me. I rushed, not realizing that the patient also arrived with a head injury and a small subdural hematoma revealed by a CT scan. I did realize eventually, but nurse had already administered apixaban. Tense call with on-call hematologist who basically called me a moron, to which I did not disagree. Thankfully, no harm to patient, but slight dent to pride and confidence. Next story. As an F2, I accidentally discharged someone from ED with a troponin of 10,000 as I mixed up 2 patients with chest pain. I looked at patient A's bloods, which were normal, went to the room to speak to them, and they answered to a patient A's name, advised him all was good and he could be discharged. Then went to see who I thought was patient B, but it became very obvious that was not who I was speaking to, and realized I'd mixed them up. Quickly extracted myself from the room, and looked up patient B's bloods, and my stomach dropped out in panic at the trop, which was the highest I'd ever seen. Thankfully, the emergency department's consultant I ran to in a panic was great, and we quickly got the patient back to the department and treated. The moral of the story? Always ask the patient their name. Never ask if they are Mr. Smith. Next story. I once prescribed a fluid bolus over 2,000 mins because I was used to prescribing the duration by rate in med school, and the electric prescribing software did it by the actual time you wanted something infused over. Noticed immediately and sighed. Next story. Not backing myself on an instinct on F2 medical on-call nights. I saw what I thought was a bowel obstruction with significant new bilious vomiting. Previous surgical history in the abdomen, and hadn't opened his bowels for over a week. Surgical show told me to do a PR and a lactate and call him back. Obviously empty and lactate of 4+. Patient is very sweet and apologetic, and the day resident appears, assesses, says his stomach is too soft, and he looks too well, do an abdo x-ray in the morning, and leaves. I worry about it all night and then go back to the ward at the end of my shift to tell the ward round team that I'm worried about him. I come back on for the next night shift to find he died in hours from a massive bowel obstruction confirmed on CT. I was devastated. I don't know what more I could have done as the F2, but the surgical day resident had made their decision, and I felt I couldn't overrule. During the day, the patient was too ill to decompress the stomach, despite multiple attempts, and he was made DNAR despite being in for something completely unrelated. Next story. F2, surgical ward. Couldn't find tourniquet on the ward, used a glove instead for day surgery patient inside room. That patient turned out to be the trust chief executive. Next story. Being on call as an FY1 during a norovirus epidemic when everyone else called in with the crap. It was me and remote supervision by phone from a med reg in a toilet for the whole of the Sunday. Next story. Not me, but this one time, when this doctor said to the consultant that this estranged daughter of Mr. X has come from America and has weird questions, only to open the curtain and she meeting us saying, "Hello, I am the estranged daughter." Next story. Overdosed someone on quetiapine, rendering them completely unconscious for about a day. Underdosing someone else on low molecular weight hormones, resulting in a submissive PE. Both had mitigating factors and are common and usually harmless mistakes, but I was still the last link in the chain that ultimately failed to prevent an error with serious consequences. Both made early in my career, and both very useful learning experiences. Next story. I have 2 that I still think about from time to time. First one, as an FY1 about 4 or 5 months in, working on a very busy 42-bed AMU overnight, where it was normal to clerk 10 admissions whilst enacting all of your own plans. Nurses didn't do ECG, bloods, cannulas, etc., in addition to any other ward job generated and looking after unwell patients. Optimal staffing was theoretically 4 residents, first-year residents, second-year specialists. Vast majority of time it was 3 or even 2 doctors. Anyway, that shift there were 3 of us, but it was bed blocked. I'm not sure if it was Ed making a fuss or the med reg requesting help, but the other 2 residents went down to Ed to clerk the patients accepted for AMU, leaving me alone on the unit. The crash call went off whilst I was cannulating someone. I didn't think much of it at the time. The crash alarm goes off semi-regularly on this unit, and it's always a false alarm. Except this time, I walk into the bay and see one nurse applying the defibrillator pads and another nurse performing CPR on a 65 years old multimorbid man. Chronic kidney disease stage 3, diabetes mellitus type 2, previous necrotizing myocardial infarction. This was my first ever experience with CPR, resuscitation outside of the dummies from Ill's training at med school, but as the only doctor present, I was implicitly expected to lead until the resus team arrived. I think I said something stupid to begin with in a panic, asking whether the patient actually was for CPR. Confirmed he was. I got access, albeit with a small bore cannula, and I waited for what felt like an eternity for this resus team to show up. 2 minutes go by. The defibrillator performs the rhythm check and stated, "Shock ready," or something similar. I instructed nurses to deliver the shock. This repeated twice before the resus team finally arrived. In the intensity of the moment, I did not consciously interpret or recall the rhythm displayed, nor did I administer any drugs before senior support arrived. When the arrest team took over, the patient was in asystole. Blood gas showed profound metabolic derangement with severe hyperkalemia and acidosis, and subsequently, resuscitation was unsuccessful. During the post-event debrief, I was asked what rhythm the patient had been in prior to defibrillation, which I couldn't answer. There was no blame attributed, but I felt very embarrassed and inadequate. I had always struggled with imposter syndrome, and I felt like I had just made a massive mistake. Was this patient in a non-shockable rhythm, and I delayed giving him adrenaline? Did my shock or delay of administering adrenaline contribute to his ultimate demise? It was a pretty crap feeling that I carried for a while, and perhaps naively kept thinking that when it mattered the most, I messed up the first actual opportunity of being a doctor. I've since been involved with maybe a dozen or more resuscitations before eventually transitioning to psychiatry, and I understand pretty well the limitations of resus, even with a perfect adherence to ALS algorithm. I still think about that case from time to time, more to reflect upon systematic failures and to be kind to myself. To be honest, I'm not even sure if the defibrillator would have allowed me to deliver the shock if it was non-shockable. Who knows? Who cares at this point? Next story, was about to do a lung biopsy on an obvious cancer on a 55-year-old. Went through all the possible complications as usual, asked him to sign the consent form and said it's the usual legal gobbledygook that says if anything goes wrong, it's not my fault. He said, "I know, I'm the hospital lawyer. I wrote it." Next story. In 1997, instead of taking a show job, I should have done an MBA and transitioned to either investment banking or consulting at someone like McKinsey. Second is not taking a consultant job in Canada. Next story, obstetrics and gynecology. First week in post. Post-op hysterectomy patient. We will call her Angela Raspberry. Started complaining of a sore throat. One of the other juniors fobbed her off. Didn't call ENT. By the time I saw her, she was stridulous, epiglottitis, airway closing. I crash bleeped. No one came. She's turning blue. Can't intubate past the swelling. I know what needs to happen. Cricothyroidotomy. I'm a resident physician registrar. I've never done one. I've seen one on a video during a lecture I was half asleep for. But she's dying. Right there. Right then. So I cut. And I got it wrong. She died. Afterwards, I nearly told the family. Had the words ready. My consultant stepped in, talked over me, talked for me, made it sound like an unavoidable tragedy. One of those things. Doctors look after doctors, he said later, like he'd done me a favor. Next story. On my on-call, I prescribed Sandokai for a patient with low potassium, with instructions on the prescription to review after 3 days with daily bloods out for the next 3 days as well. Potassium was 4.2 on day 3. No one reviewed the Sandokai, and they continued it for almost 2 weeks. Potassium was 9.1 when it was rechecked. Patient was okay, luckily. I was an FY1, and this patient was on a surgical ward. In hindsight, I should have been more defensive in my practice. The consultant who had rounded on that patient the whole week without reviewing meds or bloods immediately put a defensive note to cover himself. Nothing came of it except that all Sandokai prescriptions automatically stop after 3 days instead of being reviewed after 3 days. I only found out because the FY1 who rounded with the consultant told me. Next story. Spoke to the show from a different specialty rather than the reg directly when discussing a patient, which was the pathway, but the patient was complex and probably needed a senior opinion. This may or may not have resulted in a delay to a decision about treatment. Ultimately, patients didn't want them to have the treatment anyway. But had the decision been made earlier, the patient themselves may have been able to have a say and may have chosen differently. Felt guilty about this was for years. Patient had a very peaceful death though, and had a terrible quality of life prior. Next story. I'm sure not my worst mistake, but I felt so guilty for until I called micro. I was an F2 working on urology. I'd prescribed someone with a shocking Aki full-dose gentamicin without thinking. The next day on the ward round, their gent level was absolutely off the chart. I called micro expecting a deserved blocking, and instead got a, well, they're never going to get another urinary tract infections again, are they? And then said something like, just recheck levels in a few days. Prescribe this ABX instead. Next story. Sent a patient home with acute mastoiditis on a CT scan from ED because my dumb brain just didn't register it when reading the report. Rang him at home. And then, as he was clinically well and already had some oral antibiotics, spoke to ENT and booked him into hot clinic the next day anyway. But I felt dumb explaining that to the ED consultant. Preemptively, Datixes myself and everything. Next story. During my orthopedics and surgery rotation was when this mistake was made. I was night doctor. The day SPR was in ED doing an ankle reduction, so couldn't make handover. So it was just the day doctor and I. He handed over 2 patients waiting to be seen. I trusted this colleague and accepted the handover, as at the time, felt he had given me all the correct information. I called the SPR, explained there are 2 patients waiting to be seen, and he said, yup, the day doctor informed me. Go see them. So I did. I saw one was obviously shortened and rotated, the other dementia patient, so no anamnesis, really just saw the ED documentation, carer notes, pain on SLR but no rotation, shortening like the other. I did the fascia iliac block for both, as in significant pain, and went upstairs to theaters where I usually sit to document my clerking, do the meds, etc. I pull up the x-ray for PT2, and guess what? I don't see the fracture in the second patient. I panic a bit, call my SPR and said, have you seen the x-rays? He said no. He said the day doctor must have. ED misdiagnosed the x-ray, and so did the day doctor. I panicked, as I have now numbed this poor PT's entire leg for no reason, called my SPR in shock and explained. We organized CT as PT still had hip pain. CT was normal. Yup, that taught me a few things. 1. Always double-check handover. Pull up the computer. I now never accept referrals or handover without being by a computer, so I can check A, they speak. 2. To always be open and honest, with colleagues and patients. Next story. As an FY1 working in a procedural heavy specialty and getting quite confident in certain procedures, although granted with supervision, on general take end of long day shift, 9 p.m., after a 7-day week and patient needed procedure doing, that could have waited till next day. Consultant asked me if I would just do procedure now, and despite it being post my home time, feeling very tired and not confident in doing it out of hours, with slightly different equipment, set up, I wanted to people please, impress, and said I'd give it a go. I did grab a reg to watch me, but he admitted to me he wasn't that confident in what we were doing either, and I defo had a gut discomfort about proceeding. Long story short, procedure went wrong, resulting in extended admission for patient, extra testing, and worry for PT family, and lost sleep for me, reg, consultant. Thankfully, ended up being no lasting harm done, and patient was fine in the end. Never agreed to do anything I didn't feel 100% comfortable with since, and would never dream of touching anything procedural at 10 p.m. in unfamiliar environment that could wait till next morning nowadays. Was a valuable lesson for me in learning to say no to my seniors, as well as some obviously practical learning re the procedure. Next story. Prescribed prophylactic antibiotic for SBP for the wrong patient. Thankfully, patient picked it up and didn't consume it the next morning till we went for rounds. Detoxed myself, did duty of candor, and reg was a sweetie who didn't make me feel bad about myself. But yes, never again because I ate fire for 2 hours straight thinking I'm going to lose my license. What's the worst med error you've seen? I saw a new grad nurse blousing a bag that, from a distance, I could tell was not IV fluids. And I walked over and asked if she needed any help. And I saw that she had bloused at least half of a bag of fentanyl. Next story. Nurse programmed the PCA pump incorrectly and bloused the entire syringe within minutes. Luckily, patient was a drug user and had a crazy tolerance, so he was fine, and actually asked for more of whatever that was. Next story. I had a friend that worked rapid response. She was called to a respiratory distress and found out the nurse gave 1 milligram of fentanyl instead of 100 megacigrammabs. The physician had mistakenly put in 1,000 megacigrammabs and pharmacy didn't catch it. She asked her if, at any point, it seemed off to her that she was opening 10 vials of fentanyl for one dose. Nurse said the doctor ordered it, so I did it. Patient ended up on a Narcan drip. Next story. FEMA contract during the height of COVID bloused an entire 500 milligrams bag of heparin. She was trying to sedate the PT with on-pump fentanyl boluses. PT hemorrhaged and died. Turns out she had lied extensively about her background to go earn that sweet FEMA money. Caught some charges and lost her license. Next story. I was maybe a month or two in the resuscitation. I wasn't a new grad, but wasn't familiar with a lot of the meds yet. A patient was being prepped for a procedure in the room. The surgeon told me to administer a booster dose of 40 milligrams of propofol. I heard 40 milligrams. I acknowledged 40 milligrams, but once I started drawing it up, my brain shut off and it became 40 milliliters in my head. I drew up 10 milliliters and administered it. I drew up another 10 milliliters and administered it. Then another. It's been about 2 minutes at this point, and the surgeon says, "Did you do it? You should be done by now." My brain turned back on, and I realized what I just did. The patient's blood pressure and heart rate start crashing, and we are now in a code. We got circulation within a minute, because he was already intubated, and there was a bag of levothyroxine hanging, but I was still absolutely mortified at what I did. The surgeon was talking to my preceptor saying, "I just don't get it. I was perfectly clear. He acknowledged me. I wrote an incident report, but nothing else happened to me. I never made a mistake like that again and became the charge nurse after a year on the floor." Next story. Cardine started on patient on pressors. New grad nurse confused it with cardizem. Patient died within minutes, couldn't be revived. Sentinel event, nurse lost her license. Hospital got sued bigly. Next story. PT came back from cath lab with heparin running at 10x the rate it should have been. Our pumps and electronic communicate, and we're required to scan the pumps to program them, especially with high-risk drips like insulin and heparin. The patient had a brain bleed and died. The nurse that set up the pump without scanning it and the cosigner both got fired. Next story. Running vasopressin at 0.4 units min instead of 0.04 units per min for about the whole 12-hour shift before I came in. I discovered this in report as I was about to receive the patient, but too late. Kidneys were gone, and the person had underlying heart failure. Coded within the hour, lost them. Expected to go to court, wrote the whole thing up. It's been roughly 11, 12 years now, and I haven't heard anything. Next story. Only ever seen near misses or small errors, because in Australia, every neonatal drug is a 2-nurse check, and every dangerous drug is a 2-nurse check at every point. Think antihypertensives, insulin, narcotics, etc. So it is hard to mess up too badly unless you both have your brains fried. I did see a nurse make up heparinized saline for line patency at 10x the concentration on accident, but we realized it almost immediately and just remade it. Beauty of the 2-nurse check. As hard as it can be with staffing at times, it does work to protect patient safety. Next story. Brand new nurse who had been off orientation less than 3 weeks. We had received a court order giving us the authority to medicate a patient. The doctor ordered haloperidol decanoate, 100 milligrams, Q4 weeks. She drew up haloperidol lactate. There is a big difference between the two. Decanoate is the long-acting injectable version. You give it once every 4 weeks, oftentimes to people who will not be compliant with oral medication. Lactate is what you give to acutely agitated patients. They can get it every 2 hours. This error gets worse when you consider the fact that lactate comes in a 1 ml vial, where 1 ml equals 5 milligrams. You'd think at some point she would stop and say, "This doesn't seem right," when she has to draw up 20 vials. Or maybe she would think that when she needs several syringes worth of medication, or needs several different injection spots. Complete and utter lack of any critical thinking. Next story. The biggest mess up I have ever seen was an insulin intravenous administration order. It was supposed to be 5 units, and the girl has 5 milliliters or equivalent to 500 units. The patient actually ended up being fine, but was on a D20 drip and receiving occasional pushes of D50. My night consisted of a lot of glucose checks. Next story. A new nurse gave IV labetalol to the wrong patient. It was a shared room. Another nurse ran IV Vanco open accidentally, and patient got Red Man syndrome. Next story. When I worked bedside in neuroreanimation, there was a new grad being trained by one of our best nurses. New grad was nearing end of orientation, so preceptor tried to give her a little more autonomy. And by that, I mean let her go hang a fluid bolus by herself. Easy enough, right? New grad hooked up NS bolus to the patient's endovascular drainage. Yes, she removed the safety port off the endovascular drainage line to do this. Yes, the patient died. Preceptor never really recovered from this, as she put too much of the blame on herself. I don't think she took on another student for as long as I worked there. Next story. Nurse put an IV into an artery on a guy's arm and injected Levophed into it. I think it was in the oar. Over the course of about 2 weeks, his hand started to turn black and blue, and I believe it had to eventually be amputated. He had dementia in his 60s, and it was a really weird case overall. I don't think the nurse got in any trouble. Next story. I was a new grad in intensive care unit, fresh off orientation. Telenurse mixed up her insulin and heparin vials and gave 100 units of insulin. After she realized her mistake, she quickly admitted to it and walked out, never to be seen again. Interestingly, the patient ended up being admitted again 3 years later, and her family recognized me from that night. Next story. Not me, but when I was in school, my professor shared that a nurse she worked with hung ABX and epidural medication. PT complains of insane back pain and feels weird. Traced lines, and ABX had been running into her epidural line. Epidural medication running into venous catheter. Next story. Patient was having chest pain. Blood pressure 70/40. Coworker gave nitro. Patient started to go unresponsive, say incomprehensible things, but I did understand. She said she started to feel high. Next. Blood pressure 60/30. Next story. I remember telling a travel nurse during report that a patient was starting IV antibiotics, but the provider has not put in the orders yet. Came back from my night shift, asked if the patient started the antibiotics yet. She said, yeah, but the patient didn't like them. At this point, I was kind of confused because the provider was ordering IV antibiotics. So I said, oh, did it bother their IV site? The travel nurse said, no, I put it in apple juice. She had my full attention. What do you mean apple juice? It's supposed to be IV. Then she had a nerve to argue with me. No, it came in a syringe. I said, yeah, we have syringe pumps for antibiotics. Look at the order. It states IV. Then she nonchalantly said, oh, well, I gave 2 doses like that. I mean, is that serious? She seems okay. Anyways, ma'am, what? First of all, you gave it wrong, and it's supposed to be 8 hours apart, and you gave them within 2 hours back to back to a 90 years old. Reported her. She got let go, and the phone call to the provider and the pharmacist was such a joy. Had to watch that patient like a hawk for the rest of my shift. Next story. 1. Flying to get a patient who supposedly aspirated a foreign body. They had not. They were intubated for a panic attack. Was told the patient was exquisitely sensitive to propofol and was only able to tolerate 0.2 micrograms, kilogram, min. Any titration caused a plummeting BP, even by 1/10 of a microgram. Walk in to find the pump running very fast. Turns out the nurse has inverted the concentration and volume, and the pump was dosing based on 100 milligrams, 1,000 milliliters, instead of 1,000 milligrams, 100 milliliters. Nobody has noticed, and this 25 years old was really on 80 micrograms, kilogram, min. 2. In the cath lab, interventionist wanted a bolus of 50 of norepi. Nurse heard that and pulled 50 milliliters out of the 4 micrograms, milliliter bag, and pushed about 40 milliliters of that out before someone noticed and said, "What the heck are you doing?" Next story. A nurse at my hospital hooked up propofol to an NG tube, and a nurse on my unit fed an HIV plus mom's breast milk to the wrong child. Neither ended up with severe harm, but just like, what the heck? Next story. I've heard many horror stories, but the worst one I've seen on my unit was a nurse administered a liquid oxycodone through a PIC. The patient had no adverse reaction. The nurse, she was the sweetest lady ever and was fairly new, and because they promote just culture, she didn't get reprimanded or terminate. They allowed her to reorient extra days and revalidated competencies. Next story. I was a nurse in the neonatal intensive care unit, and in the spirit of full disclosure, I heard about this from other staff. Baby over on the critical side of the unit had a bag of some med or another running. It was a weekend, so instead of our dedicated neonatal intensive care unit pharmacist, neonatal intensive care unit pharmacy was closed on the weekends, the main farm downstairs had mixed the bag. It had been running for an hour or so, when it just so happened our dedicated pharmy walked into the unit and went into the room where this bag was hanging, for some total other reason. As he walked in the room, all of a sudden he laser focused on that bag of meds, walked quickly across the room, and stopped that pump, while calling for the nurse. Turns out, they had put the correct med in the bag, but instead of putting the med in the expected bag of saline, it was a bag of heparin, and when they checked the label, no one ever thought to check the bag. The pharmy only just happened to recognize the printing on the bag and realize it was heparin, which we would never use in neonatal intensive care unit. Amazingly, the baby was fine, but we've all heard the stories, Dennis Quaid's babies, but it scared all of us. To this day, when I would check a bag, I always turn the bag over and check the fluid it is mixed in, to make sure it matches. Next story. All I can say is patient received 10 times the dose of vasopressin, and it sent them into true cardiac standstill because it way overdistended their heart and blew their aortic suture lines from surgery. 1 hour post-op. They survived 2 months on ECMO. Can't give any more details, but it was so sad. I cried quite a bit because I not only did their case, but had to ECMO them. Next story. A nurse administered medication to treat carpal tunnel syndrome without a doctor or respiratory therapist present in the room. They were overdue in Epic. Luckily, the pulse ox alarm raised some eyebrows, and patient was quickly bagged and tubed. Next story. I don't know if this counts because it wasn't really an error on the nurse's part, but instead an error on the pump side. A chemo that was supposed to run for 24 hours was instead bolus over like 4 hours due to the pump malfunctioning. Wasn't caught until they noticed that the bag was almost done, and it was barely hung, but pump was displaying the right settings. Next story. Near miss. Nurse got extremely close to administering an insulin drip. On a med-surg floor where it's not allowed due to PT load, without the required glucose checks ordered or planned to be done. He didn't know they were needed because we weren't trained on them because we weren't allowed to give insulin drips. That one ended up a huge line of questioning because the doctor should have ordered the glucose checks and a transfer to a higher level of care. The pharmacy should have questioned why it was being sent to the wrong floor, and the tube system used was not supposed to be able to send critical care meds to our floor without an override approval from a critical care nurse. And the nurse should never have tried to hang it. Thankfully, he mentioned something about an insulin drip when 3 of us were at the desk discussing another issue and happened to overhear. Next story. Incorrect route. Had a patient with a femoral central line running sedation, pressors, etc., except it was actually in the artery, lost their leg. I actually caught another one months later. Accidental artery placement. I saw blood was pulsating in the line. That one was resolved quickly, fortunately. We were transducing every off-unit place central line for confirmation for a while after. Next story. Nurse was giving the patient oral meds, had them in a cup. Patient requested they be crushed because she was tired, and nurse didn't pay attention to the meds she was giving. Gave crushed nifedipine ER. About 30 minutes later, patient started decompensating and almost coded. They considered ECMO. She was insanely hypotensive, but they ended up doing high-dose insulin protocol for calcium channel blockers, and patient stabilized. Not a lot bad happened to the nurse, but I believe about 2 months later she quit and now works in a clinic. Next story. I was precepting a new nurse on her last day of orientation, and she gave a whole stack of meds to the wrong patient twice. The 2 patients were both the same race, built, approximate age, but on completely different meds. I told her this is going to be a long night. We need to call the docs, file incident reports, and we'll probably have to check up on these guys all night. She said right to my face, I did the same thing the other night and we just let it go. Nothing happened then. Do we have to do all of that today? Next story. Old nurse at retirement age connected a Fent drip bag to patient before connecting it to pump, and then unrolled the clamp, bolusing 1,000 micrograms of Fent over 5-10 minutes. Thankfully, they were already vented and sedated, and did fine riding the vent with some extra Neo for a few hours. That was her last shift as a nurse and quit the next day. Next story. Night shift. At 9 months pregnant, I drove through a snowstorm to get to work. Arriving an hour late and in a semi-delirious state, I gave 60 units Lispro, rapid, instead of Lantus, long-acting, to my patient. Luckily, I caught the error immediately. Called on call, who ordered Q15 glucose checks, D5 infusion, and basically to feed him as much as he can tolerate. Poor guy was A plus OX3 and just mowed sandwiches all night. He ended up being fine, but crap. I quadruple check insulin now. Next story. 600 milligrams ketamine, intravenously. The doctor filled the syringe and injected the drug into the nurse. The nurse did not ask questions about the size of the syringe. Patient was fine due to a history of OOD, but had to overcome a gnarly sympathetic storm first. Next story. Not my med error. My patient, Marfans, manipulated the IV pump, which caused an entire 500 milliliter bag of heparin to infuse very quickly. I came back from my break to mayhem. The patient admitted to fixing the pump because it was beeping and he was trying to sleep. He was given protamine sulfate and ended up being okay. He told me that he does frequently, but this time he fixed it while his eyes were closed. Next story. When I was a nurse, a travel nurse I was working with would pull all her patients' meds, all 5 patients, for the morning and stick them in different pockets and then head out for her med pass. Gave one patient 2 patients worth of metoprolol and Lasix before spotting their mistake. The nurse stated that she saves the barcode, so she just scans it after the patient takes the med. The patient survived, but was up in the resuscitation for a couple days on a drip, learning. Scan those damn meds before giving them. Follow-up. A couple weeks later, she was let go. She was a 100% fake nurse who bought her degree in Florida. Next story. When I was a new grad, literally first week in orientation in the ed, I had an anaphylaxis PT. Doc barked out a bunch of orders and I said, "Do you want all of those intravenous injections?" He said yes. But what he really meant was everything IV except the 0.3 milligrams of I'm epi, and assumed I knew that. In some capacity I did know that, but just followed what the doctor told me. My preceptor was standing next to me but wasn't watching me super closely. IV pushed 0.3 milligrams of epi on a conscious PT who was like, "Whoa, I don't feel good." HR 180s for like 5 minutes, then calmed down. PT was fine. I felt damn terrified, like I was going to end my career before it started. But Doc was awesome and took the fall, telling me, "I made an assumption, and you asked and administered correctly according to me, so it's my fault, but it's all good." Never again have I made a med error, and this was a lesson for both of us on making assumptions. Next story. A nurse that said they were in Alcoholics Anonymous, but smelled like alcohol. Management knew, switched up 2 patients' medications. It was sad. One of the patients had ODed on benzos, survived, but had some cognitive deficits. The nurse had given the patient benzos in the mix-up. The patient was doing well before that. After that, the patient began exhibiting medication-seeking behavior. The nurse was let go quickly after this. Next story, the worst one I've seen? I almost gave a patient the wrong meds when I was a student. When a floating nurse came to our floor to cover a sick call and put her patient's meds in my patient's med drawer, the patient said they looked different, and then I noticed they weren't right. Scared the crap out of me. One time they hired a charge nurse in our nurse, or who had no or background, and she was trying to help us set up a cataract surgery, and she pulled ceftriaxone instead of Ancef and put it on the sterile setup. The scrub nurse was new and trusted her charge nurse to select the correct medication. It was injected to the eye. After the fact, when it was discovered that it was the wrong medication, we tried to find out if ceftriaxone is toxic to the eye and found no data. I think the patient was okay, but it was scary that we might have blinded someone instead of helping them see. Made me sick. This was a long time ago now, but I don't forget. Next story. My first week on stock at my new hospital, I grabbed bags out of the 10 mech potassium bin in the back room without double checking, put them in the Pyxis pocket in the resuscitation, and went on with my day. Got a call from the unit a few hours later. The person who puts everything away had put a whole box of 20 MEQ into the wrong bin. And thank goodness the resuscitation nurse pulling read the bag before giving it to the patient. Our 20 MEG is supposed to be labeled with giant orange stickers saying, "For central line administration only," but they weren't there, so my brain went dumb and I didn't double check. I read every bag, no matter what now. Next story. A nurse hung vasopressin instead of vancomycin. Patient passed away a few days later. When she was pulled into the office to explain, she lied and said she never did that. Next story. Had a young, mid-30s, PT on our unit that was end of life, comfort measures. He had a history of narcotic dependence, abuse. So when they started him on a psychotropic anemia, his doses were insane, and they were being increased fairly regularly. He was getting IV Dilaudid, both continuous rate as well as on-demand doses. So he was burning through Dilaudid cartridges and needed new ones frequently. They eventually changed the concentration of the Dilaudid cartridges from 10 milligrams Miller to 50 milligrams Miller. Problem is, when his nurse saw orders go in for the PCA, she thought it was just an order renewal and didn't actually look. So when she went to change the cartridge later in the shift, she didn't realize they had increased the concentration or changed the PCA dosing orders and never adjusted the pump settings. It also wasn't caught by the co-signer who just signed off in the computer and ran. So this PT ended up getting 5x the dose of Dilaudid he was supposed to be. Any normal human would probably be dead. But because of this guy's history, tolerance, he started tripping balls and was completely erratic. He ended up having to go to resuscitation because he needed to be sedated. The PT eventually passed in resuscitation, and afterwards, there was a hospital-wide re-education on PCA pumps. Next story. Had a nurse with 30 years experience orienting on a new unit. The preceptor was busy in an emergency situation and asked the orientee to give vancomycin orally to another patient in her tube. Gastrostomy. From rooms away, I heard the vent alarming and went in to check, and there stood this nurse at the head of the bed with an empty oral syringe. I asked what she was doing, and she said, "Giving the vancomycin." I got a bad feeling and asked where she gave it. In the trach, duh. That was a fun call to the doc and to pharmacy. Fortunately, RT was right on my heels when the vent was alarming. Next story. A patient with leg ischemia required a heparin infusion. The nurse administered a bolus of the entire pre-mixed heparin bag and then connected another heparin bag to start the infusion. Next story. This is why psych. Damn, all of this bloused heparin and fentanyl crap. No, ma'am. Worst I see in psych is someone nurse dosing a 0.5 milligram tab of clonazepam because 0.25 milligrams is annoying and doesn't do anything. Next story. Nurse gave Flomax 40 milligrams instead of 0.4 milligrams. Missed by the nurse who inputted it as a home med on admission, by the MD who ordered it inpatient, by the pharmacist who approved it, by the pharmacy tech who stocked it in the drawer, and by the nurse who administered the 10 capsules. The patient went to the resuscitation, extremely hypotensive, but afterwards probably never peed better in their life, lol. Surprisingly, the patient came back to the hospital again a couple times later, as they were chronically ill before all of this, and even had the same nurse, who of course had no repercussions. I dread taking patients from the nurse, as all of their morning intravenous antibiotics are always clamped and not given. Crazy how some nurses just slide under the radar in this profession. Next story. Bolus a full 100 milliliter bag of 100 units, milliliter insulin at $999. Patient was fine after some time on D10, but that was a bit harrowing to watch. Had a different nurse give 10 250 micrograms tablets of digoxin. Patient was good after getting a whopping dose of Digibind, fortunately. Med errors are scary. Next story. My friend went to pull up subcutaneously heparin and insulin at the same time. You can imagine what happened. Luckily, she had someone verify it, and they caught it before it made it to the patient. I don't ever draw those two up at the same time because I've had nightmares of this exact scenario. Next story. One of my coworkers' dad had cancer and was a patient on our unit. He had a chest port. One of my other coworkers, who was taking care of him, gave him a bright purple medication IVP through his chest port. That was indeed a liquid oral medication. Drew it up from the red little cup container it comes in and everything. Next story. Patient came straight to us from the OR with a 500cc bag of heparin instead of NS as the A-line pressure bag. Patient was fine. Not sure if any ever actually got flushed, but I nearly crap a brick when I saw it. Next story. Had a nurse on the oncology floor about a patient on a chemo pill. Patient had just started on this particular chemo, so they didn't know otherwise. I didn't see the exact instructions, but apparently they were confusing. I believe the dose was 3 pills, and she gave the patient 15 pills. Cancer be gone, I guess? Next story. Amio ordered. Cardine hung without scanning. Programmed as Amio. They couldn't figure out why the patient's blood pressure kept tanking until they expired. Next story. I was working at a hospital that wasn't yet using scanners. Thought I had pulled Tylenol. Went to give it and was like, "That's weird, I swear I pulled Tylenol." Went back to the Pyxis to pull the correct medication, and turns out pharmacy had put the wrong medication in the Tylenol slot. Next story. New grad nurse on orientation gave 1 bottle of sublingual nitro instead of 1 tablet. Just salt and pepper shakered it into the patient's mouth. Thankfully, the preceptor was in the room at the time. Just had her back turned, so she didn't witness it happen, but noticed after the fact. Got the team in the room fast, and got the patient set up on some pressors to ride it out. Next story. One that I thought was a mistake, but was not. A patient ordered 900 milligrams of Seroquel, Ambien, and Benadryl at bedtime. Also had PRN Ativan. First, I'd never seen 900 of Seroquel at once. Add all the other crap and absolutely not. Called doctor. Nope, it's right. Called pharmacy. Is all that even safe? Yep, that's his regular home meds. Verified twice with home pharmacy. Asked the charge that worked the night before if he was a rapid. Nope, all good. The guy still got Ativan at 0100 and was still awake at 0400, talking about our meds aren't crap. Can he get something else for sleep while pacing the hallway? How he wasn't dead, I have no idea. Next story. I gave 10 milligrams morphine IV push when the order was for 1 milligram. I had been drawing up the whole bottle, then wasting 9 milligrams with a nurse. But I was tired and forgot a step. ER patient was a known drug seeker, so he was fine. He came in several more times that month and would ask for me by name. Next story. Had a FEMA nurse give unit of blood for a hemoglobin of 13. Another FEMA nurse verified it. Pretty sure they had 6 months year experience making the big bucks. Next story. New grad ran paralytic as a intravenous administration of the drug. With a fast rate, new grad orientee didn't draw before flushing a CVL lumen on an hours-old transplant. Flushed a lumen full of nipride. Patient was reopened and washed. Bedside tamponade. Baby nurse gave 3 cc's of short-acting insulin instead of 3U, then argued with both patient and husband. Husband called the attending, who called the unit, and said, "What's going on?" We had to come scoop her to resuscitation for a dextrose GTT. I've seen a fair amount, but these stick out at the moment. Next story. Backstory. I was the Don in a maximum security male prison. At the time, we had a small, 24-man death row unit. An older man, in a wheelchair, assigned to that unit was insulin dependent. The nurse, relatively new nurse who was pursuing her NP, administered his ordered Lantus dosage. Instead, she pushed regular insulin. At that time, we admin their meds on the block, so as soon as she got back, maybe 10 minutes after, she realized her error. She freaked. She ran to me. We called the inmate to the infirmary. At the time, he was fine, just bewildered. Like, "Why am I here?" he asked me. "Am I dying?" I responded, "No, sir, not today." The dose was at least 30 units, but honestly can't recall the exact amounted. We gave D50 and IV D5, and of course kept him in the infirmary overnight to monitor his blood sugar. Thankfully, he was okay. She, on the other hand, she is now an NP and is as completely insufferable as she was prior. She's that nurse that is superior to every discipline she perceives as less than her. Just arrogant. Which, by the way, is a cover for insecurity and lack of confidence. One would hope that the experience would have humbled her. It did not. Next story. A new nurse gave liquid, not IV, paracetamol intravenously, and then removed the cannula trying to hide her mistake. Patient ended up in high dependency with a nasty cellulitis. We had to call poison control, and no one really knew what would happen as a mistake like that had never been made before. There is a reason why our IV syringes don't fit onto the NG tubes. The nurse had to be supervised giving meds for the next 3 months, and her colleagues lost a lot of confidence and trust in her as she originally tried to pretend it never happened. She kept her job, though, and still works there. Next story. Watching a junior colleague preparing a dosage of 15 medical wems of potassium chloride, ready to be administered by direct IV without dilution. Of course, I stopped them and explained in private why you can't do such a thing. Next story. I saw a nurse give 1G IV Vanco Q4H when they were supposed to give the PO dose for C. diff. Not sure how many shifts. They kept overriding the MAR warning for wrong med. The PT ended up in the resuscitation with kidney failure. I'm now sure of the outcome, but 2 weeks later was still on dialysis. Next story. I'm a midwife and had a baby that went to resuscitation, Get mom's dose of gentamicin because the lines weren't reconciled before the dose was hung. Baby had kidney issues and was being monitored for hearing loss. Next story. Just recently heard that a nurse on my unit from years ago hung a Lasix GTT as a secondary and bolused the whole 500 milligrams. Apparently the patient was okay, but started shouting, "My ears are ringing." Next story. Not me, but a new grad nurse on my unit. Subarachnoid hemorrhage patient. On nimodipine 30 milligrams Q2H. PT intubated with NG. Our nimodipine comes in a gel capsule, so we stab it with a 18-gram blunt needle, draw it out, then place down NG tube or SL depending on order. This new grad nurse gave it through the patient's IV. PT went from stable to on 3 pressors. New grad nurse had had this patient for 3 nights in a row and had given this med every 2 hours, but from some reason, 0400 on that last night, they decided to give it IV, changed our policy. Now we have special syringes to draw up the nimodipine and have alerts and second checks. Next story. During my final clinical rotation this past spring, I was in a surgical resuscitation at one of my city's largest hospitals. This wasn't my patient and had happened on the previous shift, but word of it was going around because of just how bad this was. A patient had a rapid response on the med-surg floor and was transferred to us. This patient in particular couldn't take oral meds, but had IV access. When report was called from the floor to the resuscitation nurse noticed that on the patient's file, it said they had been given potassium. She asked the med-surgeon nurse if that was a charting error, but as if it was the most normal thing to do, the nurse from med-surg said no, it wasn't an error. Apparently, this nurse hand ground up the potassium, dissolved it in a goddamn saline flush, and given it via the patient's IV. At least now the mystery was solved as to why the patient had needed a rapid response. Yeah, that's a pretty big mistake, and this nurse definitely needs some education on the subject. But the worst part is that the med-surg nurse went back into the patient's file and uncharted it. That part is a huge mistake on her end, and I'm pretty sure she no longer has a job at that hospital. Next story. Nurse gave insulin to patient with blood sugar levels of 60. Mr. Smith had all 4 limbs straight up in the air, think dying cockroach move, and his eyes were bugged out and rolling around. That was the nurse's last day. Next story. Didn't see or experience it myself, but it was one of my professors. There was a nurse who was coming off orientation. Patient was hypoglycemic. Nurse was told to get juice to give to patient. She injected orange juice into their IV. Patient ended up being okay because of immediate action by the team. Apparently, the nurse went on to be an incredible critical care nurse. Absolutely wild, but clearly shows a lack of education. Next story. Not really an error, but one I could see coming. I worked in a resuscitation where newborns like to draw up post-sucrose in IV syringes instead of using the handy-dandy oral syringes that were always available. They also like to run their tube feed syringe pumps on the same pole right next to their IV syringe pumps. I walked out of there on a Friday night on my last week of orientation, emailed HT and my manager, and quit. Next story. So, you know how the subcutaneous heparin and the IV heparin for boluses come in different vials? Well, I go to do my 2100 meds, pull the heparin from the Omnicell to give subcutaneous, and it's the wrong vial. I go to check the order, and the physician had put in the IV concentration as subcutaneous for prevention of deep vein thrombosis. I'm like, this is different. I was still a new nurse. I had been on my own for a few months, and I assumed it was just something I had never come across. I went to ask the charge nurse about it, and of course she's like, no, that concentration is IV only. I explained that this was what the Omnicell gave me, and it matched the order. She told me not to give it, and she goes to check the chart. The patient had been on the wrong concentration of heparin for over a week, and I was the only person who said anything. It became a hospital-wide teaching moment because the physician put in the wrong concentration, the pharmacist approved it, and then multiple nurses either administered it or overrode the Omnicell and took out the correct concentration. This was also about 5 years after Dennis Quaid's children died from being given the wrong heparin concentration. So the hospital admin was like, literally, how did this happen? Next story. Coworker had a patient fall and had a bleed with a midline shift at about 2200. Didn't ask about reversing heparin or anything else. Also didn't discontinue the upcoming dose or mention it to the doctor on the phone. Gave 0600 dose at 0500. She comes to me at 06:15 and asks me to look at her guy. He won't wake up. Go in, PT completely obtunded, pupils jacked, unresponsive to pain, etc. At the time, our floor was split between the 5th floor, which had our charge on it, and the 2nd floor, the unit we were on. 3 nurses, 15 PTs, no tech, charge 3 floors up. Progressive resuscitation floor. I immediately call charge, tell her to order a CT, tell them we're coming now, and to get her ass down here now. Bleed was out of control and patient died on day shift. Sentinel event. Coworker resigned. Not too long after that, we moved intensive care unit to across the hall from A and made it 20 beds. Charge still split between the two, but at least they were on the same floor. Next story. A new nurse on orientation in my old unit went to hang IV potassium as a piggyback, but accidentally connected the piggyback tubing below the pump, and the patient got bolused with 20 MEq of potassium. I don't recall the specifics of what happened after, but PT didn't die. Next story. We had a new grad orient bolus a 20 MEq bag of potassium through the patient's port, just wide open right into his heart in minutes. Patient was thankfully okay. Next story. I once worked in a nursing home facility with a nurse who took off an order for Lovenox. It was supposed to be every 12 hours subcutaneously. She put it in as every hour, so she gave a lot of doses. What's even worse is the nurse that followed her did the same thing. They said that night he was hemorrhaging from every possible orifice. This is a seasoned nurse who was level-headed, and I can't believe she didn't question it. And I use this story when training new grads about not blindly following orders and to use critical thinking skills. This was an older man in his 60s who was there for short-term rehab and who was returning home to his wife and kids, and grandkids who died a horrible, unnecessary death. The nurse had to pay a ton of money for a good lawyer, and who was suspended for a while but continued to work afterwards. Next story. When I was a new grad, I tried to flush a PICC line with heparin rather than heparinized saline. I had actually checked it with my NUM. Luckily, the PICC was blocked. It didn't go through. Next story. Back when all charting was on paper, we had a patient transferred out of resuscitation. The med floor nurse called me to see if I had the bag of scheduled antibiotics that wasn't brought to the floor. She was looking for the Levophed. She thought it was Levaquin. It was still listed on the paper MAR. Medrecs weren't automatically flagged to do upon transfer like they are now. We were both horrified at how that could have turned out. When I think about how many med errors are made with scanned meds, can you imagine how many were made when we didn't scan? Next story. New nurse off of orientation has a PT on BiPAP in resp distress that was not tolerating it. WAB was a way up. The PT just looked bad. The ed doc was reluctant to reverse transluminal therapy inhibitor for whatever reason. Finally, decided that she would, so she put in the reverse transluminal therapy inhibitor order set. Apparently, the nurse saw the orders and gave the meds. Like managed to go pull etomidate and sucks, draw them up, and give them before RT, MD, and a second nurse got to the bedside. Next story. I don't know if it was the worst, but it's up there. Intravenous administration of Cardin at the infusion rate of Keppra. I had complained and complained about the new nurse, still on orientation in our ICU, and no one would listen even though I was the preceptor, not by choice. Then she did that to my patient 6 weeks into orientation. I lost my crap. The only reason that patient didn't code or die is because the patient had an art line that alerted me to low pressure, and I immediately saw what she had done and stopped it. The nurse had been a traveler, so she had tons of experience. This was not a new grad. I think she flew under the radar traveling. Anyways, that was it for me. I went to the nurse and told her I wasn't coming back until she was fired. I called out the next night and then went on a vacation I had planned. They fired the nurse while I was gone. Next story. Order to replace gastric output 1-to-1 through their central venous catheter. Nurse was pushing their gastric output through their central line to replete them instead of IV fluids. Not sure if the order specified what to replete with, but my first thought would never be to literally give them back their nasty gastric juices through their central line. It's the story they tell every new grad at my old job. Next story. When I was a resident, a cardiologist was a surgical patient. Not sure what surgery he was having. A newbie nurse had him and was so nervous working with him. She accidentally flushed his IV with lidocaine instead of saline. She was so afraid. Came to me and asked what to do. She called her supervisor and reported the error. I explained to the PT what happened. He asked her to come in. No problem. Most of it would be gone on first pass through the liver. She was still nervous as hell but survived. Next story. A new grad had an order for IV phenobarbital. She didn't have the IV med, so she ground up pills, mixed with tap water, and gave it IV. PT was already highly compromised with a head injury. I was a student extern and don't know what happened to the patient. The nurse was fired. Next story. I had a new grad who gave 10 milliliters of ketamine instead of 1 milliliter. The worst part is the provider administered it. He asked her how much it is, and she said 200 milligrams. And he said okay and gave half of it. It was 20 milliliters in a 20 milliliter syringe. The entire vial of ketamine. We only had the huge one stocked in the ER at the time. She felt rushed and thought it was normal because propofol comes in a large amount, so she didn't question it. The patient would not wake up, complete K-hole, for like 3 hours. It was not normal, and the nurse admitted to me that she made a mistake. Thankfully, it was ketamine and the PT didn't overdose. Just took forever to come out of it. When he finally woke up, he said he felt like he just took substances. The nurse acted like he must have no tolerance and never told the provider about the med error. I helped her monitor the patient, and when she admitted what happened to me after the PT was discharged, I educated her and told her the PT is okay, but that she needs to be way more careful because she could have killed him. The provider trusted that the nurse knew the med, but he also should have realized 10 milliliters was way too much to be ketamine. Just an overall fail, but thank God the PT was okay, and the new grad hasn't made any mistakes, that I know of, again. Next story. Not as bad as some of these, but I used to work inpatient psych, and we offered the influenza vaccine during flu season. The flu vac is refrigerated. A PRN nurse gave a 12-year-old 2 milliliters of Ativan instead of the flu shot. The flu shot is in a pre-packaged syringe at my facility, so the nurse had to make a lot of mistakes along the way to give Ativan. Pulled the wrong med, didn't scan first, didn't read the vial. 5 writes out the window, obviously. Kid ended up being okay, just had a real good sleep. The nurse tried to cover it, so she ended up being reported to the board. My director told me if she had just done the appropriate medication error incident reports, that she would have been in a way better situation. Next story. Nurse hung levo instead of nicardipine on a patient with a hemorrhagic stroke. I caught it during report. Pump was programmed correctly for nicardipine, but the medication running into was Levofed. Med was never verified by a scan. Damn near shat myself. Check your drips at change of shift, and don't skip scanning meds. Next story. The evil Empire Hospital Corporation I worked at had a CT tech who accidentally injected CT contrast into someone's ventric drain, thinking it was an IV line. Patient passed away. Next story. I'm a nurse's assistant that has paid his dues in the resuscitation. I reported that my nurse gave a patient an oxy when he was supposed to get Advil. He's an 82-year-old diabetic with a gangrenous foot with low blood pressure. He cannot take a double dose of oxy. Instead of doing an opiate protocol, waking him up and getting Narcan on board, she took an Advil and gave it to the guy whose oxy she had accidentally stolen and then fudged the chart to make it look right. When I saw her coming out of the wrong room, I pointed that out and she looked stunned and played it off. 3 minutes later, I was in a room and her station was right outside the door, and I heard her whisper, yelling, "Crap," under her breath at the charting station. This was right at shift change, so I didn't wait around to see what happened. I came back the next day, and he was dead. I quit, reported to the state, and filed for unemployment. It was approved. Next story. Resuscitation new grad didn't bother to pay attention to what drips his patient was on when getting report. PT was on Levofed, and pressures were climbing. Nurse kept giving PRN metoprolol IV push for high pressures. By the time a senior nurse caught on, it was too late. Patient crumped, and family chose to withdraw care because of her age. He still has a license and a job on a med-surg unit. Next story. Med error that happened to a patient at another facility. They dosed 152 milligrams of methadone when the patient was previously on 120 milligrams the day before. Not permissible, even under Medify guidelines, when the recipe was actually for 60 milligrams. It happened for several days. So many mistakes and jumping safeguards had to be made to make that error. The patient ended up being okay, but very uncomfortable for a while. Next story. I was helping a travel nurse set up for an art line insertion. I had pulled 2% lidocaine for the doctor to administer subcutaneously and set it in the room by supplies. The doctor scrubbed in and asked for the lidocaine so he could draw it up, and I realized the whole 20 milliliter vial is empty. I asked the nurse what happened to the medication, and she said she had given it IV push. Luckily, the patient was okay, but it was so scary. Next story. A coworker added an entire bottle of insulin to a parenteral nutrition bag. I think the order was for like 10 or 12 units, and they injected the full bottle. The patient BS crashed, and they became unconscious but lived. Next story. Our acute care floors recently rolled out a hyperkalemia protocol with IV insulin pushes. New grad and a train wreck of a charge nurse together give 1,000 units instead of 10 because they got the concentration confused. Apparently, I was not present this shift. Immediately after giving the push, the charge says, "Wait, how much did we just give?" Their lack of following basic med administration rules is shocking to me. Patient survived with loads of D50. Next story. In 2022, Redonda Vaught, a former VUMC nurse, was found guilty of causing the death of a patient by accidental injection. On December 26, 2017, Vaught mistakenly administered the paralyzing drug vecuronium to a patient instead of the anti-anxiety sedative Versed. The patient died the next day. VUMC fired Vaught on January 3, 2018, and the district attorney's office arrested Vaught for her alleged role in Murphy's death on February 4, 2019. Redonda made a med error. Here is the bigger issue in your medical, nursing career. You will have a medication error. We all do. Redonda did what 99.9% of medical professionals would not have done. She owned her mistake. She stayed. She assisted in the patient's attempted resuscitation efforts. She was fired and then lost her license. The case drew criticism from every bedside nurse. The family of the patient did not want her to lose her license, although tragic, was an honest mistake. So before anyone passes judgment on Redonda, thinking you will never have a medication error and sit on your high perch, you will. The question is, what will you do when it happens? Next story. Saw a miscommunication between an anesthesiologist and anesthesiologist recently. I'm holding the O2 mask. The cons. Pushes the fentanyl, saying we're going to pop you off to sleep. Suddenly, the PT stops breathing. He realizes what's happened almost immediately, tells me to start bagging, and starts talking to the PT explaining what's happened. Despite them being completely unresponsive, he draws up and then pushes fent again, and then propanol rapidly, and so I can get an airway in. Took us a couple of minutes to figure out how it had happened. Turns out our fent and rock ampules are nearly identical. His usual anesthesiologist always keeps the rock in a separate drawer, but this one normally puts it on the side, but not in the tray. Basically, rocuronium got drawn up instead of fentanyl and mislabeled for a routine day case. Inesthetic. Fully conscious PT gets paralyzed with no warning to anyone, including us. Worst error I've ever seen managed well, purely because the anesthetist was so experienced and recognized it immediately. Next story. Pharmacy sent us a mislabeled insulin drip instead of an epi drip. They slapped the wrong label on and everything. I don't know how they figured it out. I'm assuming someone called down to the ED, but also a farm tech came running and screaming, "Don't start that drip!" all the way down to the trauma bay with the real epi drip in their hands. Next story. Some nurse at an old people farm gave the wrong dose, concentration of morphine to a patient. So instead of getting 20 milligrams, 1 milliliter, the patient got 20 mls of a 20 milligram, 1 milliliter dose. Needless to say, that patient died because that facility is where people go to be neglected or murdered. Next story. A new grad nurse going through an entire bag of nicardipine in like half an hour somehow. She may have been trying to titrate it, but kept hitting the wrong setting on the pump. Next story. When I was working in the interventional radiology department, we had a patient who, as far as I remember, was given intravenous heparin and arterial TPA for 24 hours for thrombolysis. The nurse in cath recovery bolused heparin and switched lines when replacing bags of meds. They replaced the entire line and bag, even though we gave detailed, strict instructions not to, and provided both replacement meds as well as specific times each med would finish and be DC or replaced. I mean, handwritten instructions that stayed with the patient. Everything was very clearly labeled on lines as arterial, and then separately with med, and then venous with med. Yet they still swap them, and one infuses way faster than the other. So, Homie ended up having even more frequent PTT than planned, was going to resuscitation anyway, thankfully, and luckily, no negative outcome. I wondered just how they deliberately messed that up and kept their jobs. Next story. Funny enough, I had an employee almost give a patient 10 milligrams of semaglutide today. The only reason it didn't happen was because she came to get me to say, "We don't have enough vials for this." Wouldn't have permanently harmed the patient, but they would have the most miserable 72 hours of their life. Next story. Morphine drip running at the rate of the carrier and carrier at morphine drip. The lines were crossed. PT was hospice and responsive only to pain before the drip was started. Next story. I was going to co-sign a heparin GTT when I noticed the ml seemed awfully high, so I double-checked the dose. They had the weight programmed as their height in centimeters, so instead of 70 kilograms, it was entered as 176 kilograms on a weight-based GTT. I was like, let me double-check the dosing on this real quick. They must have glanced at the wrong number somehow. They were mentioning how they had to keep pausing it because the PTT was too high. Welp, I might have a guess as to why. I always double-check whenever I co-sign GTTs, especially weight-based ones. Next story. Coworker gave a newborn a Tdap injection rather than vitamin K. Hospital is rural. L&D meds are combined with med, surge, and ED meds. Vitamin K and Tdap right next to each other in the fridge. Next story. A colleague gave a newborn a Tdap injection instead of vitamin K. The hospital is located in a rural area, and medications for the maternity ward are combined with those for the medical, surgical, and emergency departments. Vitamin K and Tdap are kept next to each other in the refrigerator. Next story. The nurse working in the emergency department asked me to sign an authorization form for intravenous heparin. When I entered the room, she was also about to start intravenous diltoid in the same line. The patient's blood pressure was 60/40. She was in atrial fibrillation with a heart rate of 107 beats per minute. The nurse had already administered intravenous metoprolol twice. The patient was admitted to the emergency department, and the internist prescribed a standard prescription for intravenous metoprolol every 5 minutes for 3 doses with a systolic blood pressure greater than 180. The nurse observed that the patient was in atrial fibrillation with a heart rate of approximately 160 beats per minute. She consulted the emergency department physician about this, and he prescribed home metoprolol 150 milligrams extended release, as the patient had not taken her home medications that day due to her stay in the emergency room. The nurse administered the medication orally, and the patient's pulse rate remained elevated. But the emergency room physician on duty overnight, who had not admitted the patient, advised calling the primary care physician. The primary care physician advised administering metoprolol intravenously. The nurse administered it, and 5 minutes later, while the pulse rate was still elevated, she administered another dose as prescribed, 3 times every 5 days. She had not taken the patient's blood pressure into account. Before the second dose of metoprolol, the patient's systolic pressure was 100. The second dose dramatically dropped it to 60/40. So when I went in to authorize the heparin drip, I panicked about the pressure and said we urgently needed intravenous fluids. The nurse said, "I'm starting a dildo hematoxylin IV." What? I told her not to start it, that the dildo hematoxylin would only lower her blood pressure even more, and she looked at me like I was a deer in headlights. This is a contract nurse in her 50s. That's basic nursing knowledge. I was shocked. The next blood pressure dropped even lower, and her pulse was already around 90. I immediately administered a liter of fluid under pressure, and this nurse called the doctor on duty and asked him to come to the ED to examine the patient because of her low blood pressure. She said it like it wasn't her fault, like something was wrong with the patient, and he needed to come immediately. I couldn't believe it. When he arrived, he told me to administer another liter of fluid under pressure. At that moment, the oral metoprolol also started working. The doctor on duty didn't know that the ED doctor ordered it. A complete failure on this nurse's part. She nearly killed this poor patient. She shouldn't have given a second dose of intravenous metoprolol, especially 5 minutes after the first. The patient didn't have hypertension to begin with. Her systolic blood pressure was 150. She should have told the on-call doctor that the patient had received her oral dose. She should have told him about the patient's blood pressure, and I guarantee he would have simply ordered a diltisulfate IV. We don't need a guarantor for diltisulfate, so if she hadn't tried to start the heparin at the same time, no one would have noticed her mistake, and the patient's blood pressure would have plummeted. She even told me she was going to give a third dose of metoprolol, but she saw that the primary care physician had ordered a dilta sulfate IV. I reported the medication error, and the contract nurse was fired 3 weeks later for various other errors. I don't know if she was just following orders and had absolutely no nursing sense. Hard to believe considering she'd been a nurse for over 10 years, or if she was out of her mind, or just in a rush, or something else entirely. But she literally dropped the patient's blood pressure dramatically, focusing solely on the heart rate and panicking about it. I've never seen anything like it. Next story. An experienced and qualified nurse working overtime on the obstetrics unit intended to administer an antibiotic to a patient, the course of which was supposed to last more than 30 minutes, but instead accidentally administered an epidural infusion bag, which was also in a 50 milliliter bag, and administered it at the same time as other procedures, also more than 30 minutes before the scan. The patient passed away. Next story. New grad gave port Tylenol in a PICC instead of the G-tube on a step-down unit. They decided to put the PT in the resuscitation overnight just in case, and he felt perfectly fine, lol. No symptoms. So weird. Next story. I work in the OR, and our anesthesiologist will pretty much bolus IV antibiotics prior to incision, and never look at the med. They trust what the nurse gives them. Pharmacy had sent up an IV bag of what was supposed to be Flagyl. It was labeled Flagyl. The charge nurse brought it to me like they usually do. I turned it over to see that it was a bag of 40 MEq potassium. Not exactly sure how bad that would have been if 40 of K was infused within less than a minute, but I imagine it wouldn't be good. Another time, not my OR room, the nurse mixed their own 2 grams of Ancef in a syringe, put it in their pocket, and also put a syringe of either lidocaine or bupivacaine in their pocket. The nurse handed the wrong syringe to the anesthesiologist, and the patient got a whole bolus of local anesthesia and in resuscitation stay because of it. Next story. Received a PT from the ED, started on insulin GTT. Dosage was 10 times the starting dose, and PT was getting 80 units an hour. Bag was only 100 milliliters. PT arrived on unit with an empty bag of insulin. PT was fine, but the fear of them developing cerebral edema kept me worried. Next story. I didn't personally witness this, but a nurse where I used to work handed a whole 100 milliliter bottle of liquid amlodipine to a patient, without measuring the 5 milliliters they were supposed to get. Next story. We once admitted someone to nephrology intensive care unit from the emergency department, and discovered they'd been given a 24-hour furosemide infusion in 1 hour, because the pump had been programmed wrong. It sorted their overload out. They'd have come to us anyway, but yeah. After that, we changed the protocol. Those patients would get an initial bolus dose in ED, but the infusion would be started on arrival to us. And if they needed it starting in ED due to capacity, bed weight, etc., one of us would go down and start it, and they had to be catheterized before it was started. Similar thing happened with an insulin infusion once, although I wasn't there that day, which must have been scary, and a couple of staff faced disciplinary retraining. Both patients were fine in the end, but it's still frightening how easily catastrophic errors can be made, especially when staff are under pressure. Next story. Heparin infusion on a wandering dementia patient. New grad got the APTT back and titrated the amount accordingly, but instead of 1.5 milliliters, she had it at 15 milliliters hour. The poor patient was forced to sit still so he wouldn't fall and bleed out. It was only picked up because the bag went dry before then end of shift, and they thought it was too soon. So they checked the machine and realized what had happened. Next story. Not a nurse, but had a patient come up from the ED who was in DKA and had soft tissue infection, and the numbnuts ED nurse had given the entire 100U bag of IV insulin, intending to give the antibiotics that had been ordered. Luckily, the 100U wasn't even enough to get the guy out of DKA, but that should have been lethal. Next story. I responded to an emergency case where a young graduate and her intern programmed a patient-controlled analgesia (PCA) pump to deliver 5 milligrams of Dilaudid as a loading dose instead of the prescribed 0.5 milligrams. The patient suffered cardiac arrest. He survived, but I understand there are concerns about traumatic brain injury. Next story. A pregnant coworker in the resuscitation went on break, and her vented patient desatted right after she left. She had mixed up her pumps and was also bolusing fentanyl. Thankfully, this patient was vented, It hadn't even been 5 minutes, and nothing happened except increased vent settings for an hour. She sobbed when she came back, but was incredibly careful after that. Pregnancy brain is real. Next story. Years ago, when Alaris PCA pumps were brand new at our hospital, another nurse pulled me into her room to look at the PCA. The fresh post-op patient was sitting up, comfortable and chatting with family, while almost the whole 50 ml syringe of morphine went in less than an hour. It should have lasted for a few hours. I double-checked the settings on the pump, and it was correct. Pharmacy, risk management, everybody got involved. We never found out exactly what happened. Glitch? Or maybe somebody saw the error, corrected it, then called for help. Next story. Not bad, but one time I pushed 50 milligram Benadryl pretty fast, undiluted, for a PT in the ED with hives, and she instantly clutched her throat, and it was obvious she couldn't breathe. Her O2 sat was 100%. But I put her on a non-rebreather and ran to get the provider, who was at the nurse's station couple doors down. By the time we got back to the room, she was fine. Labored breathing, still sating 100. Provider said it must have been a strange, sudden onset reaction that resolved quickly, and that if she continued feeling dyspneic, we could give epi. I apologized profusely to the PT as it scared the living daylights out of her. On the bright side, her hives were starting to disappear. Next story. Had a new nurse push milk of magnesium IV. No reasoning behind this given. She just said, "I thought that was right." Lost her license 6 months after getting it. Gotta be a record. Next story. A nurse I worked with infused a whole bag of mag into a preeclampsia patient at the bolus rate. Patient ended up in the CCU. Now we use separate bags. And by the way, she was an excellent nurse. Patient lived, but family sued. Next story. Order for U500. The primary nurse asked me to co-sign for the administration, but hadn't gotten the glucose level yet. He looked angry, shocked, and huffed away. I assumed it was to get the BG. I see a few minutes later another nurse co-signing with him. Less than 30 minutes later, our endocrinologist comes marching down the hall, get the manager to pull the 2 nurses into the office. The glucose level was never checked before the U500 was administered. It flagged in the system that the morning labs had not resulted, and the glucose level was not checked manually prior to administration. The morning labs had resulted about 10 minutes after administration. Glucose level was 49. Next story. Bolus flowing open, heparin 25 KUI flowing via pump. Nurse didn't track the lines, so the heparin was gravity flown wide open, and LR was running on the pump programmed for heparin. Next story. During nursing school, I saw someone pull up like 4 grams of magnesium into like a 20 ml or bigger syringe, because the order just said administer IV push. This person was being precepted as a new nurse, and her and the preceptor checked with the doctor. Then they checked again with the unit pharmacist. Both times they got waved them off. They gave it, and the patient went unresponsive for a minute, but they came back. It was just supposed to be a mag replacement. Next story. A patient I took care of with cerebral palsy was receiving sodium phosphates for 3 days. Pharmacy has to send up the bag pre-made, and I noticed that when I was trying to program the pump, I kept getting a guardrails warning, the pump's way of saying, "This sounds like a lot of medication, are you sure?" Previous nurses ignored it and ran the medication, but I stopped and called pharmacy and realized that they were giving a patient who actually was a pediatric weight the adult weight dose. Thankfully, the patient was okay. The order was verified by pharmacy, ordered wrong by the provider, and was given for a couple days, but I wrote an incident report and got the patient the right dose. Next story. When I first started nursing, I had an 80-year-old patient with persistent high blood pressure. He was on a liquid form of his blood pressure medication. I had a lovely student nurse for the day who was taking over his care with me as a support. She did a great job, and the group left after lunch. I repeated his vitals in the afternoon. Everything was great, except now his blood pressure was way down to a pristine number. I could not figure out why, but he was asymptomatic and chatty. So, being a new nurse myself, I just let it go without investigating it further. The next day, I had the same patient assignment and the same student nurse. She comes up to me with her facilitator, tearful and beside herself. I pulled them aside to the med room so they could talk to me. Well, the student nurse realized that morning upon doing her double check that she had miscalculated the dosage and given him, remember this was 20 years ago, so details have escaped me, 10x, maybe more, of his dosage yesterday. I reassured her that he was okay and thanked her for telling me and assuming responsibility. We did the incident report together, and I got the answer as to why the man finally had a great blood pressure. Next story. Calcium gluconate on the pump. Labetalol via gravity. Patient died. Family didn't make a big deal. Manager promoted that nurse to charge nurse a month later. Next story. Watched an extremely experienced and kind of a pain in the ass CVICU coworker bolus an entire 250 milliliter bag of insulin into her intubated patient because she popped the tubing out of the pump for some reason before going to CT scan. After many amps of D50 for BGS in the single digits, they lived. Next story. Bival GTT post-stent in cath lab. Usually they come up with it running at the rate it runs during the cath, and you just let it keep running until the bag runs out, like 15 minutes. The cardiologist wrote the order wrong and wrote for the intra-op dose to be a continuous GTT. Imagine a heparin drip, but probably literally 100 times stronger, like running a bag of heparin to gravity all night. Night nurse and the charge nurse called to question the order. Then the pharmacist called the cardiologist to question the order too. He screamed at us and told us that they're called orders for a reason. Blah, blah, blah. So the night nurse ran it at his ordered rate. Patient spontaneously hemorrhaged and died before the night was over. We MTP'd them and everything but couldn't replace fast enough. The nurse reported it to the state under safe harbor after the hospital, HCA, unsurprisingly, did literally nothing and blamed the nurse for negligence. The doc tried to throw nursing under the bus, but the nurse took extensive notes and state took her side ultimately. I don't know what happened to the doc. I got out of that hospital the second my contract was up, and I haven't seen him anywhere else in the city. Next story. A nurse I worked with took the dilaudid syringe intended to be hooked into a PCA pump and pushed it into a peripheral IV over like 3 minutes. The patient coded, ROSC obtained. Then the patient was transferred to resuscitation and put on a Narcan drip. Still ultimately ended up passing away a few days later. What are some of the mistakes you've made as nurses? Mixed up meds between 2 patients. No harm done. They were almost identical, except the other patient had a crap load of sedatives in hers. But the patient who got the sedatives was annoying as F. So no harm done there. Next story. Scrubbed in during a cranie. The bone flap, which was maybe the size of a $50, was wrapped in a moist lap. I forgot and mistook it for a regular dirty lap and threw it in the kick bucket. They couldn't use it anymore. I've seen some literature that it could be flashed or soaked in betadine, but thankfully it was small enough to be covered with a small plate for bone to regrow on. I was a few months off my 7-month orientation. I cried so much. To my and my manager's surprise, the surgeon, a really good man and really good doctor I respect, actually spoke up on my behalf, telling them to take it easy on me because he knew I did good work and worked hard otherwise. I'm pretty sure he is why they took it easy on me. That was over a decade ago. I still share that with new grads and new surge techs to remind them to be easy on themselves when they make mistakes, because most already know the high stakes and are hard on themselves. It's also a reminder to myself not to judge myself based on one moment alone, because I am all of my work, not just a single mistake. Next story. I held a Claritin because the patient didn't want it and returned it to the Pyxis. When I got home, I found a Claritin in my pocket. How did I get an extra Claritin? Did I return something else? Everything was scanned. I'm so confused. Next story. Forgot to check a Vanco trough. And I should have held it. Thankfully, our culture is supportive, and I felt totally comfortable reporting it. Oh, and I DC'd a patient with the telebox on. That sucked. My manager had to drive an hour to go retrieve it. Next story. I accidentally gave a patient 1,000 times stronger a dose of an allergy immunotherapy shot as a new grad. Ironically, it was the day before my RN NCLEX exam, and while I thank God every day that the patient lived and didn't go after me, it still haunts me, and that was 8 years ago. Next story. New grad as of like 2 months. I went to flush a G-tube with breast milk and didn't close the med port, and it came right out and squirted me in the eye, and had to do the whole employee health thing. Next story. I scanned a bunch of pills, and one of them K was supposed to cut in half. I saw it pop up, but by the time I finished scanning, I forgot. It was just a PPI, so no harm done. But now when I get a partial package pop up on Epic, I stop and draw up or split that amount before moving on to other meds. Next story. Another one. During new grad orientation in super sick resuscitation. Nurse left me alone to titrate like 4 pressors at once. We titrated one off. She never double-checked me. I must have gotten confused somewhere because I titrated vaso off instead of levo. Cue patient's blood pressure sucking, and no one could figure out why. Everyone running around like idiots until I said, "Can someone check behind me that I titrated correctly?" Checked behind me. I hadn't. Everyone looked at me like I was an insane person. I was very stressed and confused and getting things mixed up, but really thought I was doing it right. 100% also the nurse's fault for not checking behind me. Chewed me out after and said I really surprised her with my negligence. I'll never forget how small I felt. Patient was fine. This was a unit that would randomly quiz me. What's the half-life of rocuronium? What receptors do norepinephrine act on? And when I got it wrong, I had my ass chewed. Very toxic learning environment. Next story. I didn't have a sharps container anywhere nearby, so I decided to recap a needle. So stupid. It went through the cap. I poked myself in the thumb and spent the next 6 months terrified I would be HCV+. Next story. When I was a new grad, the doc asked for amio during a code, and I went to the Pyxis and overrode an amio drip instead of giving the push dose. Code dose. Next story. Gave patient food after his heart cath. Didn't know he's supposed to come back shortly after for CABG. No one communicated that info to me. Didn't see anything like that in the note either. Surgeon got mad as hell, but cardiologist wrote an order for diet. PT still got CABG that afternoon. Next story. I didn't scan dilaudid at the end of my shift before giving it. I was in a hurry to get everything settled and give report. I told the oncoming nurse that I had just given the dilaudid, so she knew he had gotten it. He asked her for pain meds 30 minutes later, and she messaged me because it wasn't scanned. I let my manager know immediately. Everything ended up okay, but I still get anxious thinking about it. Next story. Went to give a tetanus vaccine and apply lidocaine gel to a patient's forehead laceration from a fall. Was in a bit of a rush and started applying the tetanus vaccine right on the wound instead of the lido. Was wondering why it was so loose and then realized that I was an idiot. Next story. I disconnected a Broviax TPN and connected it to a blunt tip with a cover on it so that I could draw blood from the Broviac. It was only my second time ever doing that, and in the NICU, you almost never have lines big enough to draw blood on, so it was weird for me. Thankfully, I had another nurse with me just to give me a second pair of hands, so this kiddo didn't ruin the sterile field with his hands. I went to pull the blunt tip off so I could reconnect the lines. Instead, I pulled the cover off and somehow immediately stabbed it clean through the tip of my finger, in one end of the tip and out the other right above my nail. My nails are short. I gasped and pulled it out, and my sterile glove started filling with blood. Thank God that other nurse was there to handle my Broviac, so I didn't get my blood all over this poor child. Had to go do the whole employee health thing in the ER, which was super embarrassing, especially considering this all happened like 40 minutes into the shift. Next story. Pushed Epi-IV for an allergic reaction as opposed to giving it SQ. Also, accidentally bolused levo. These events were within a couple weeks of each other. Both patients were completely fine, thank goodness. I was placed on FMLA and never went back to my job after that. Turns out I was more traumatized and burnt out than I realized, and PTSD is a real thing. Next story. Oh, and I have a log of all my students' mistakes, and then I roast them for it. Not in a mean way. My first student gave a patient a pill lying flat and he almost choked. My second student constantly hung secondaries wrong. My third student never corrected patient electrolytes. My current student forgets to scan patients. I passed them all, not because they were perfect, but because they did what mattered. Learned from it and did better the next time. That's all you can do. Next story. So I'm a preceptor, and I tell my students every single nurse you know has made mistakes. Ironically, the best nurses have made the most. Wisdom comes from experience from mistakes. My dumbest mistake was accepting a patient from PACU with bilateral pneumothoraxes. Yes, they were transferred to the ICU the next day. As I tell my students, if they don't die and you weren't reckless, it happens. Just grow from it. Next story. Perhaps one of my faves, not my patient, but we had this new admission come in. All was well. Primary nurse completed the admission and went on lunch. Well, he buzzed for a turkey sandwich, and after confirming he could eat one of the other nurses gave him one, but didn't verify he had his dentures. This man literally inhaled this turkey sandwich whole and coated. We had to do a bedside bronchoscopy on med-surg. Next story. In my nursing school preceptorship, burn ICU, my preceptor told me to push D50 for a low glucose. I had never done that. I pushed it into a peg tube versus IV. No harm, but I should have read the box more carefully, and also asked for help assembling that crap. It's hard the first time. More recently, I've given the wrong med at the wrong time. Next story, one I caught. My coworker had swapped 2 patients' wristbands. I noticed at the first med pass after the switch, before giving meds, so no medical harm done at all. There was a breach of privacy, but the nursing gods were with us that day. Both ladies happened to be friends, and only learned that way that the other was in the hospital as well, both 1 or 2 day admissions. They would have told each other anyway. We had to do some official registration things, but other than that, nothing came from it, luckily. I've been called paranoid on checking data when handing out wristbands after that, though. Next story, when I was a new grad, like 3 weeks off of orientation in a very sick ICU, we were trying to stop a postcode from seizing. The doc told me to give 2 of Ativan, so I gave 2 milliliters of Ativan, which was the whole vial. Super stupid, but I had no idea what I was doing. He told me to give the other 2, the rest of the vial, and I had to tell him in front of the entire code team that I had already given the rest of the vial because I thought he meant 2 milliliters. Blank stares and complete mockery of me for the rest of the code. I was mortified. My charge nurse was a huge bully, so I didn't feel comfortable asking for help when I didn't understand the dosing in a high-pressure situation. Always ask. Can't actually remember what the med was. I don't know if it was Ativan or something else, but imagine if I had given double the dose of something that would have hurt someone. Always ask. Next story. Anytime I fumble an IV start, I should have gotten. Had a patient yesterday on Plavix for a long time, so veins are of 2 camps. Made of rubber or made of Squidward's hopes and dreams. Took me 4 sticks before I got a pitiful 22 grams on his contracted side. Poor guy. Next story. I hung 2 bags of Dobutrex instead of 1 of Dobutrex and 1 of dopamine. Nurse following caught it right away and let me know she fixed it. Thanks, Barb. Next story. Had a doctor as my patient, and after his shower, I cut his PICC line while unwrapping the plastic bag I had put over it. Luckily, they were able to attach a new line, and he was actually very cool about it. Next story. Also recently, I discharged a patient and gave them the wrong meds. It's easy to do in ortho when everyone is pretty much discharging with the same meds, Oxy, Senna, etc. But I gave one person meds belonging to another person that was leaving the next day. So that created problems when they didn't have the meds, and pharmacy insisted they'd sent them, because they had. I thought I had double-checked the bags, but always triple-check IG. On the bright side, my system is now looking into making it so you have to scan the discharge meds, rather than having random grab bags stuffed in a cabinet. Next story. New grad as of like 2 months. I went to flush a G-tube with breast milk and didn't close the med port, and it came right out and squirted me in the eye, and had to do the whole employee health thing. Next story. I moved around some meds to different channels, but not the rate. I gave a 3-year-old 12 hours worth of lipids in 2, because it was running at the TPN rate. She was on it at home too, so the parents totally knew my mistake. She was perfectly fine, but I felt like crap. Next story. A patient needed potassium IV, and she had a midline. For some reason, I had it in my head that I could treat it like a PICC, and ran it as such. It infiltrated, and she ended up screaming and crying from the pain. I was floating and ended up crying uncontrollably because I felt so bad. Plus, it was like the day after Redonda's sentencing, so I was extra on edge about med errors. Everyone, including the patient, was really nice about it, but I felt like an absolute idiot. Next story, new grad med-surg nurse gave sumatriptan IV instead of sub-Q. At least at my hospital, it's not recommended IV period. Like it's not a route of administration, told my manager. She helped me remain calm and had me tell the doctor. Then I started a chat with the doctor and the pharmacist. Patient was not harmed, put him on telly, and I monitored the crap out of my patient. I discharged him a few days after. That made me really stop and process what I'm doing. Even in a stressful situation with the patient, fully A+1 mind you, screaming at me. I definitely learned with that one. Next story. Just the other night, I had a traumatic code, and my first code as primary nurse. Patient did not survive, and the family's cultural beliefs dictated that he had to be picked up by their funeral home within a certain amount of time. In all the whirlwind of the code and post-mortem care and supporting the family, the funeral home showed up, and I forgot to get a copy of the body release form before they left. It was the middle of the night, so the day shift charge had to call the funeral home in the morning and get them to fax us a copy. All in all, it ended up okay because we got the copy, and I'm never going to mess that up again. Next story, I have a resident. Her weekly Neupogen injection. And when giving report to 210 nurse, she says, "I already gave that to early." What? Excuse me? You have it early, didn't document it, and never passed it along in report. So I guess realistically, it was directly my fault. PT had dementia, so she didn't remember already having it. Reported my mistake, and her nephrologist said she could use the extra dose anyhow. No harm to her, and just a warning to me and the other nurse. Next story. One time I had this patient come in with pancreatitis near the end of my shift. He had visible fat when they drew blood, so we knew that cholesterol was off the charts. Well, he came in with only a few hours last of my shift. I got everything done, gave him everything that was ordered, and finally, when he and his roommate, Looney Tune guy who had fallen already that shift and had to have security called on him, were finally asleep, I realized I didn't hook up his fluids. I let them both sleep as they had been up all night, and told the oncoming nurse I hadn't had a chance to hook up fluids. Continued on with my second admission that night. Apparently the next shift, he had to be moved to ICU after his cholesterol labs results, because he needed plasmapheresis. Shocker. And they tried to blame me for not giving the one bag of IV fluids. It was a whole crap show, and the nurse I told I did not have a chance to hook up fluids also did not hook up fluids, so I went down instead. New grad, lesson. Do it yourself, don't trust another incoming nurse's word. Next story. I gave a vitamin IM instead of IV. I almost gave Benadryl instead of Decadron, but caught it when doing 5 rights. I work in quality at the hospital and handle adverse events, mistakes every day. My best advice without knowing what happened is that it is in the past and you cannot change it. But you can change moving forward. Learn from it, grow from it. Change your practice so that it never happens again. It is likely a system or process failure and is not your own individual fault. There are always many holes to the Swiss cheese, but unfortunately, as a nurse, we are often the last line of defense, which is why it is so crucial to do all of your safety checks all of the time, every time. Next story. First time running amiodarone. I didn't know I needed the micron filter. I had crushed a patient's meds together and didn't realize I had crushed in another patient's chemo med. Thankfully, I caught it when comparing each med to the MAR and that it didn't scan before I flushed it into their NG. Next story. In ED. Titrated levo. Prop for 3 hours trying to get a dude unconscious while maintaining his BP. On the final adjustment, right before we were going to go to ICU, I put in 0.07 instead of 0.7 on the levo. His BP was like 66/40 for a second. I adjusted it right back up, but man, if there was a lump of coal between my cheeks, a diamond would fallen out. Next story. I didn't check that the pump was programmed according to the concentration on the bag during handoff. I did catch it after report, but I got nailed with the med error as well as the nurse who spiked the bag and programmed the pump wrong. Next story. I went to give my patient a heparin shot in his stomach. We got to chatting. A few moments later, I injected the needle into his stomach and pushed the plunger down, only to realize I never actually drew up the heparin. I injected air into his sub-Q tissue. All was well, thankfully, LOL. Oh, and I had a physician give me a verbal order for rhino rockets, so I called the ED to have them tube some up. I followed the instructions on the packet and inserted them myself, only to find out that nurses were not supposed to do that, and it should have been done by the ENT. Luckily, I did it perfectly, and the patient's nosebleed resolved, and ENT saw him the next day with no issues. Next story. I had 2 Betty JS. One Betty got Tylenol, and the other got Motrin. Except that one time I gave them inverse meds. That was that. No one got hurt or anything, but my manager looked at me like I was just painfully stupid and told me to document it. Oh, and that one time as a brand newbie, I confidently gave a gentleman his sliding scale insulin, nice and deep, all like in his deltoid for some unhinged reason. Like, I spaced out and just did it as if that's something I do all day, every day. That was an edge-of-your-seat style hour after, between making him guzzle flat sodas and checking his glucose way too many times. He dropped to 35 and tried to take his roommate's trash out, but he bounced right back up and had a nap after. In that case, I was quite lucky nothing worse happened. Next story. Consent read ORIF of ankle, and that was what I had the patient sign. No laterality, no full write-out of terminology. It was purely out of lack of sleep on my part, as I was on call and called at 4 a.m. for this case. But, in my defense, surgeon wrote it. Another nurse I was on call with didn't catch it either, and the OR nurse didn't notice either. But still, it was a stupid mistake. Next story. Had a lot of empty vials and half-emptied vials in my pocket, threw it in my center console, drove around, got a DUI, CHP turned in my meds, got fired, and my license taken away. Next story. As a new grad, I dealt with decreasing SpO2 by just upping the O2 to a non-rebreather and didn't think to escalate that to anyone. I'm now the lead for the ICU outreach team. I once replaced an empty syringe infusion of something with a syringe full of heparin, so the patient got double heparin and zero whatever it was supposed to be. Took a patient at her word when she said she didn't want to be turned after surgery, and she still had the diathermy pads under her, a chest drain disconnected under the sheets, and I didn't notice. Honestly, I can't remember all of them. We all make mistakes because we are humans working in flawed systems. Unfortunately, our mistakes can cost lives, so we tend to wear them more heavily. We should. It's a huge responsibility. It's hard to reconcile our humanity with the fact that us screwing up can kill someone. Next story. Just the other day, I accidentally put the wrong label on a urine specimen. It is not a huge deal, but a pain to have to call lab and ask them to cancel it. They refused to put the results in the correct chart or cancel it, so I had to email my manager. Again, not a huge deal, but annoying ASF. Next story. Once accidentally put a suppository in the vagina instead of the anus. In my defense, visibility was challenging. Also had a coworker I thought was just quirky. Turns out they were high and diverting. We have all been there. The way you are feeling now just shows your commitment to being a good nurse. Next story. The shift was good. Shift started well. No problems emerge, and then a patient came. An elderly one, needing some iron supplements through IV. I looked for a vein, was too scared to insert it in the hands. The relatives informed that PT usually get IVs in the brachial veins, so I looked there, and saw one I thought I could use. I got ready to insert. When the needle pricked, there was backflow, so I continued to insert. Then, I connected the iron supplement to the cannula. Everything was going well. PT had no complaints of pain, itching, or any other allergy symptoms. Was feeling pretty good about the patient, even chatting with the relatives. Then, about 15 minutes before IV termination, they noticed there was a bulge surrounding the IV site. I was mortified. Informed the doctor. She said it was okay, then asked for a picture. The IV was terminated, and there was no longer a blood flow. I am feeling so overwhelmed right now. It's like I failed to be a good nurse. All that talk about helping the vulnerable people, and I did a crap job. I told my preceptor they and the doctor are now talking. Turns out the patient was the doctor's father-in-law, and the relatives were actually the doctor's spouse and mother-in-law. I feel so defeated, like I don't deserve my license. The bulging was so large from the iron extravasation that I'm sure it's going to leave a permanent stain. And it's not going to heal quick because the person is an elderly. I feel so sorry for the patient. I wanted to help him and make him feel comfortable and cared for, yet I did a crap job and just gave him more problems. I don't even care about my job at this point. I just hope the patient is safe, and there is only the least as possible problems that would occur from my neglectful problem. Sorry if I'm ranting. I just really need to vent this. Thanks for reading this. Sincerely from a trash new nurse. Hope the patient is okay. Next story. Discharged a patient with their chemo port still accessed. Patient came back to the ED saying it needed to be de-accessed. Patient had to be readmitted to the tele unit to flush heparin before de-accessing the line. Felt like absolute crap and was incredibly disappointed in myself. Next story. New RN here. We were doing referrals for a possible CVA patient. They were intubated, hooked to an O2 during the ambulance ride. When at the hospital, the other staff I was with rushed so fast to the ER, someone unhooked the PT to the O2 and forgot to bring the O2 tank to the ER. Absent-mindedly, I took over to pump the ambu and only realized that they did not bring out the O2 tank with the patient when an ER nurse noticed it and the PT was massively desaturating. I was very agitated when I merely took over for literally a minute. We were only supposed to be there to assist and shadow the senior staff. Next story, dumb mistakes. Like today, I should have questioned the doctor's order. Cucks. Why would she put regular diet on a PT that has pancreatitis, SMH? Although the PT tolerated the food fine, I should have called the doctor for NPO order. SMH. I feel like I'm losing it these days.